Hello, everyone. My name is Corey Thornton. I'm the senior editor here at Open Minds, and welcome to today's Circle Executive Roundtable, the right metrics, feedback-informed care, and patient-centered outcomes, featuring Dr. Stuart Buttlaire, Regional Director of Behavioral Health and Addiction Medicine at Kaiser Permanente. Before we get started, I have a few housekeeping reminders. Your audio is muted today, but we would like to have your questions. If there's time at the end, we will answer those. You can submit them using the question box on the right-hand side of your screen. And finally, the slides and the recording for today's roundtable will be archived and available for elite members on the Open Minds website starting tomorrow. And with that, here's Dr. Buttlaire.
Good afternoon for those of you back east, and it's still morning on the West Coast, which is where I'm at. And I'm going to be talking to you today about a particular type of management-based care. There's been a lot of swirl around management-based care. Today I'm going to talk about one form of MBC that puts the client, patient at the center of care, that has repeatedly shown effectiveness. Next slide, please. It's not just a laundry list of unrelated measures, but ones that have repeatedly shown effectiveness. And I point this out because we've seen so many measurements that have come out related to behavioral health, but I really want to focus on today on measures that matter. And I refer you to John Doerr. He wrote a wonderful book in 2018 by that title, and Measure What Matters. And John was one of the early adopters and participants in Google, and now has become a billionaire investor. And he and Google spread a way in which to think about measuring. And what they talked about was the concept of OKRs, which stands for short for objectives and key results. And what they mean by that is an objective is what's to be achieved, what do you want, what's significant, what's a concrete action, and ideally it might be inspirational. And key results are related to what are the benchmarks and how are you monitoring to get to this objective. And usually the most effective results, key results, are ones that are time-bound and specific and measurable and verifiable. OKRs really do surface primary goals. They channel efforts, lending purpose both for the individual and particularly for both the individual and the organization. You know, the goals and objectives really create alignment, clarity, and job satisfaction. And that was actually a Deloitte study found that to be the case. Next slide, please. So I want to give you a couple of examples, not in our industry, but in other industries related to high tech, related to global world health, and football, sports. Next slide, please. So one example was a software company that was relatively new and getting started in Silicon Valley. And their objective was to continue to build a world-class software team. And their key results were to recruit 10 engineers, very specific, hire commercial sales leaders, and 100% of their candidates feel that they had a well-organized professional experience, even if not hired. So those were their key results that they were going to be looking for along the way to building a world-class software team. Looking at the on the right-hand side of this has to do with Bill Gates, and Bill Gates Foundation had an inspirational goal. They really wanted global eradication of malaria by 2040, and Gates actually was focused on Africa initially, and his efforts in Africa to prevent malaria in several countries in malaria, and he created and helped distribute blocking vaccines, and with the idea that they would eradicate malaria in a particular country. Well, he did a good job in one of the areas and decided he wanted to really focus on spreading it globally for not only Africa, but there's other areas in the world that really do have malaria. And so his key results was proving to the world that a radical cure-based approach can lead to regional elimination of malaria. And the second result was to prepare for scale up by creating necessary tools called the CIRAP. And CIRCAP stands for Single Exposure Radical Cure and Prophylactic Diagnostics, which is a way in which they go about measuring and helping to understand the vaccine and the spread of malaria. And the last was sustain current global progress to ensure the environment is conducive to eradication push. So you can see on this, it's a much more inspirational, much more difficult to get to, but those were the objectives and results that Bill Gates Foundation was looking to. Next slide, please. A much more realistic one and close to our what we do on Sundays is the alignment of team goals and breaking it down. And this is an example in a football team, a sports team. Well, the general manager's objective is to make money for the owner. And his key results is to win the Super Bowl and fill homestands to 90% of occupancy. Well, that translated to the head coach, who had the objective to win the Super Bowl. And his key results is a passing attack amasses 300 yards per game. Defense allows fewer than 17 points. And the special team units ranks in the top third in punt return coverage. Well, they translated that to the offensive coach, whose objective is to generate the 300 yards passing. And his key results is achieving 65% of pass completion, cutting interceptions to less than 1 per game, and hire a new quarterback coach. That poor quarterback coach, I guess he wasn't doing his job, so they think that that's going to lead to more success in terms of the passing game. So the defensive coach also pulling in these objectives as part of the team to give up fewer than 17 points per game. And his key results was allowing fewer than 100 yards rushing per game, increase the number of sacks to 3+, and develop a Pro Bowl cornerback. All those three things were going to be measurable on the way to achieving the results that he's looking for, which is fewer than 17 points, leading up, of course, to winning the Super Bowl and, of course, making money for the owner. And lastly, the special teams coach objective is improve to top 3 rankings for punt coverage. And the key results is allow fewer than 10 yards per punt return and block 4+ points over the season. So this is an example of a group of leaders coming together to produce results all the way down from the owner making money down to the different areas of the organization, providing support for that ultimate goal of making it to the Super Bowl, filling the stands, and making the owner money. Next slide, please. So what are our OKRs for behavioral health? What are our key objectives and key results? And what matters in treatment? And how are we measuring it? You know, the key to improving quality in behavioral health and other organizations in treatment is accountability. And what is our accountability is gained by measuring outcomes and learning from those results. However, in our behavioral health industry, as Tom Insel reported in his book on healing, a survey only showed that 18% of psychiatrists, 11% of psychologists, and fewer other professionals actually routinely measure and administer symptom scales to patients and monitor the improvement. So in the absence of measurement, clinicians and behavioral health organizations have not been accountable for specific outcomes. We as a business line or as an industry have not been producing results that demonstrate the effectiveness of the care that we've been delivering. Next slide, please. Although there has been a lot of starts and stops and variability, the trend is moving to value-based reimbursement. Value-based reimbursement fundamentally shifts from fee-for-service to outcomes, to being able to demonstrate the fact that people are outcomes are people are getting better, and that we're able to show to external organizations that that we are making progress. This is true in both the public and private sectors. And the question for you to think about, to consider as an organization, what does the people who support and pay you care about? What are health plan governments, boards, your boards of directors? How will you be judged, and how will you demonstrate the fact that actually we're improving our care? Next slide, please. So one particular aspect of management-based care is what I'm going to be talking about as we go on with the presentation, which is feedback-informed care. Next slide, please. So, you know, one of the leaders in feedback-informed care is Barry Duncan. He and Michael Lambert, Scott Miller, and Jeb Brown, and a host of others have actually led the way in this area. And they really champion measurement-based care and feedback-informed care. And what he wrote was, soliciting systematic feedback is a living, ongoing process that engages clients in the collaborative monitoring of outcome, heightens hope for improvement, fits client preferences, maximizes therapist-client alliance potential and client participation, and is itself a core feature of therapeutic change. Therapeutic change. And the title of his book that this quote comes from, if you have a chance to ever read it, is The Heart and Soul of Therapeutic Change. Excellent book. I have talked about it quite a bit. I will also add, when patients choose a course of action, they are more likely to see it through if they're choosing it. Next slide, please. So feedback-informed care is both a therapeutic orientation and a technique. It's a meta-theoretical approach where traditionally therapists and counselors are guided by their particular model or clinical model or technique. Feedback-informed care is guided by the outcome and alliance feedback provided by the patient, their families, and others. And it's applied really across therapeutic modalities, disciplines, and service settings. You can use any modality, but feedback-informed care can apply to all of them. It's additive, if you can think about it. Next slide, please. So what is feedback-informed care? Well, what it is an evidence-based approach using patient measurable outcomes and alliance provided by the client. You can use any form of outcome that's evidence-based, including PHQs, GAD-7s, CSSRSs, any of those types of measures, and this adds to it. The use of the therapeutic relationship discussions to maximize patient engagement and ensure the consumer, their treatment is on the right path, is considered and called goodness of fit in our system. And goodness of fit really does measure the alliance between the patient and the provider. It's not one model or method or clinician is sufficient for treating all problems. This goes beyond, again, clinical model. It goes beyond just technique. It looks to partnering with the patient in terms of whatever therapeutic modality the clinicians are already using. You know, we talk about exposure, CBT, ACT, DBT, and medication support all become more effective with feedback and therapeutic alliance, and I'll be showing you some more information related to that. But feedback-informed care, again, is a meta concept in terms of treatment modalities. Next slide, please. The settings that are being used with feedback-informed care are broad and diverse and include both adults, youth, children, and agencies, treatment settings around the world, including inpatient, outpatient, residential treatment, prison-based mandated care, case management, collaborative care models in primary care, and SUD programs, substance use disorder programs as well. So it's been found effective in all these different settings. Next slide, please. So I want you to understand, and I think mental health and psychotherapy gets a bad reputation. The evidence is that actually psychotherapy is extremely effective. In most studies of treatment conducted over the last 40 years, the average treated person is better off than 80% of untreated samples of patients. The outcome of behavioral health services equals, and in most cases exceeds, medical treatment, including medication. How is this measured? Well, a concept called effect size of treatment modalities. The effect size measures the strength of the relationship between a treatment and improvement. You can measure it by looking at depression, anxiety, and other outcome measures. And again, the effect size of behavioral health studied is about a 0.8. How does that compare to other services? Well, Viagra for erectile dysfunction has an effect size of 0.35. Prozac, medication that treats, of course, depression, has an effect size of 0.6. So psychotherapy is actually, as measured by most studies, it shows equal to or greater effectiveness than many other medical modalities. But there's a problem. And that problem is dropout rates average 47%. When half of your patients are dropping out, how do you demonstrate effectiveness? Mental health professionals frequently do not identify cases that are failing. Because we're not checking in with our patients, we don't necessarily know if they're failing, they just don't show up. And 10 to 15% of patients account for 60 to 70% of expenditures, and we're not focusing on that group of patients. Next slide, please. So one question that I get asked quite a bit, well, doesn't professional status make the difference in terms of evidence and outcomes? Well, the evidence is that there's little or no difference in outcomes between professionals, students, and paraprofessionals. Some people make that case that the professional status does count, but all the surveys that we've seen and shown over the years shows very little difference. And interestingly enough, Michael Lambert did a study that surveyed psychologists, psychiatrists, social workers, MFTs, students, and paraprofessionals, and he found no differences in how they rated their skill levels and effectiveness themselves. They rated themselves on average in the 80th percentile as a group. None rated themselves below average, and less than 4% considered themselves average. Only 8% rated themselves in the lower 75th percentile, and 25% rated their performance at the 90th percentile. Consumer outcome data, on the other hand, shows that most therapists are average and follow the bell curve distribution. So there's no way that we can demonstrate the fact that we all believe we are superior, but in fact, most are average and no better than less than licensed professionals as well. So the claims of superiority among clinical providers is without evidence, and clinical models, which I'll go on to talk about next slide. So some people come back and say, well, surely it's the medication that makes the difference in terms of outcomes. And the seminal study of medication and treatment modalities was the TDCRP study, the Treatment of Depression Collaborative Research Program that was sponsored by NIMH. And it revealed that even when drugs are involved, interpersonal factors play an important role in securing positive results, even when drugs are the primary treatment. This study, the seminal study, studied 250 unipolar depressed patients randomly assigned to 3 different sites and different treatment conditions: CBT, interpersonal psychotherapy, imipramine plus clinical management, and placebo plus clinical management as a control condition. Little differences were found between the groups, but this led to studying the doctor-patient relationship. Did the doctor-patient relationship turn out to play a significant role in improvement of depression patients assigned to all the groups? So the results showed, and I'll go on to describe some of the results, showed alliance had a significant effect on outcomes. Next slide, please. The top third psychiatrists giving placebo bested the bottom third giving medication. The clients of the best counselors improved 50% more and dropped out 50% less than the rest of the cohort. And medication was found to be the most useful for clients who had the most effective doctors in terms of their interpersonal skills and their ability to connect with the patient. Not for less. So what accounts for the variability? Next slide, please. So the alliance and the summary is that the variability of the doctor-patient relationship may account for the considerable variability in placebo and active drug response rates across studies of antidepressants. Thus, the role of the therapeutic alliance plays in affecting outcome extends not only beyond psychotherapy, but implications for the way in which pharmacotherapy is conceptualized in practice. I think that's a really important concept. Also, the study found CBT, IPT, drug placebo, no differences in outcomes. No differences in outcomes. So what did predict positive outcomes? Well, 3 client ratings in alliance at the second session was the best predictor of outcomes. So we could predict based on alliance evaluations by the patient at the second session whether or not they were going to have positive outcomes. This again demonstrates the power of the alliance. Next slide, please. Over last 60 years, the number of models of treatment has continued to grow, as you know, and the claims of superiority in outcomes have not been demonstrated. With few exceptions, studies designed to prove the unique effects of a particular model of care have found no differences on meta-analysis. So the more we analyze large studies, the more we find actually that the differences between different modalities disappear. Barry Duncan called this the dodo verdict. Those of you who remember Lewis Carroll and Alice in Wonderland remember the dodo bird. Just to remind you of it, in order to get dry after a swim, the dodo proposed that everyone run what he called a caucus race. They run in any pattern, starting and leaving whenever they like to, and that everybody ends up winning because there was no goal. All must get prizes, he says, the dodo bird says in conclusion. And of course, the concept of the caucus had to do with Lewis Carroll's political satire on Congress, their lack of clarity and decisiveness. But this shows you, again, the fact that really over the years, as we look at different models of care, really the differences disappear in meta studies. So what factors account for successful outcomes? Next slide, please. As I build this case for relationship. So this is the study of and contribution of all the different elements in psychotherapy. Well, the largest element in terms of outcomes, successful outcomes, has to do with extra therapeutic, having to do with the client. What kinds of things are we talking about here? Well, somebody comes into psychotherapy because they're depressed, because they've just lost a relationship. Well, an extra therapeutic event is actually them finding another relationship, for example, or getting a job if they've lost their job. Those are extra therapeutic, or going into nature and having some kind of a religious experience. The relationship accounts for 30% of the outcomes in most of the meta studies that have looked at over the years. Technique, that which we spend most of our time in graduate school and medical school in studying, accounted for 15% of the outcomes, which matches placebo and patient expectancy. What we expect. The more positive somebody has about the hopefulness of psychotherapy, of course, we've shown over the years that they tend to have more positive outcomes. This is a study by Michael Lambert and John Norcross. So what does work? Next slide, please. Once again, the research on the power of the relationship has been reflected in nearly 1,100 research findings. And really the relationship comes down, the therapeutic alliance predicts outcomes, and irrespective of consumer variability, their demographics in the alliance was unrelated to outcome when you look at large samples. And so what does constitute the relationship and improvement and outcomes, which is agreement on goals, meaning or purpose of treatment, means and methods, and the client view of the relationship are really the keys to improvement. Next slide, please. The relationship between the goodness of fit and outcomes has been studied in 13 randomized client trials involving 12,000 clinically and culturally and economically diverse consumers. The routine outcome monitoring and getting feedback as much as doubled the effect size. Again, the relationship between treatment and outcomes, reliably and clinically significant change, decreases dropout rates as much as by half, and reduces hospitalization and shortened length of stay by 2/3, and significantly reduce the cost of care, while non-feedback groups increase the cost of care. So the combination of getting clinical feedback and monitoring whether or not patients are progressing, and then getting feedback about the relationship, really are the two elements that increase the potential outcomes. Next slide, please. This has been true as well across culturally, not just in this country, but they found that studies in Norway and Sweden also demonstrated the fact that replicated these findings. Next slide, please. So I was very fortunate to have met Carl Rogers at near the end of his career and life. I studied for part of my postgraduate training at the Center for Studies of the Person in La Jolla, his person-centered approach and client-centered therapy. And he was right. He was on to something, that empathy, positive regard, genuineness, all are powerful than any particular technique that you can ever wield. And each of those qualities is additive in terms of outcomes. Next slide, please. So Burdine, a classic definition of the alliance, is that there's a relationship bond, agreement on goals and treatment, and agreement on how we're going to get there. That leads to 36 to 50% in most studies of improvement, and up to 7 times the impact of model and technique, and accounts for most of the variance in treatment. So I'll go back to, we spend most of our time in our careers studying techniques, and yet the essential core is monitoring patients' progress using outcome-based measurement, and the alliance. Next slide, please. We often think about substance abuse differently, but it has the same results. The Project Match was a study that looked at people who had substance use disorder care, and they were assigned to 3 different groups: CBT, 12-step, and motivational interview, all of them also in milieu treatment. No differences in outcome. The client ratings of the alliance was the best predictor of their participation in treatment, drinking behavior during treatment, and drinking at 12-month follow-up after discharge. Next slide, please. SAMHSA recognizes this, and SAMHSA has recognized the fact that patient change outcome measures added with evidence is an evidence-based practice. Adding to it FIC are both a theoretical as well as an additive to therapeutic orientation. It's an evidence-based practice now, even recognized by SAMHSA. Next slide, please. So why use feedback-informed care? Because it engages the patient in treatment planning, agreeing on treatment and their goals, and measures really the progress of treatment, and helps get the patient better and back to their lives much more quickly. Next slide, please. So what are the clinical implications of feedback-informed care? Well, therapists and organizations should really monitor their contribution to the alliance, provide feedback to the therapist about their alliance, and therapists should receive training to develop and maintain strong alliances. Those are the 3 keys of what organizations can do: measuring the feedback, giving them feedback back to the therapist, and the organization making an effort to make sure that this process happens. Next slide, please. So how do we integrate feedback-informed care? How do we create a culture of feedback? By integrating alliance and outcome measurement and feedback into practice. You have to practice this. When scheduling a first appointment, I recommend providing a rationale for asking clients for feedback regarding outcome. It's right from the beginning, letting them know we're going to work a little differently. If we're going to be helpful, we should both see signs sooner rather than later for improvement. If our work helps, we can continue. If our work isn't helpful, we'll seek consultation in 3 to 4 weeks and consider a change no later than 8 to 10 weeks. What does that mean? Well, what that means is that we're going to continue to measure how well you're doing in terms of your depression, your anxiety, and also our relationship. And if we're not seeing changes and we're not improving, then we need to think about how to change things. Does the patient need medication? Does the patient need a different therapist? Are we just not engaging really well? So this is one of the things you have to do in terms of integrating a culture such as using feedback-informed care. Next slide, please. We're freaked out about, in mental health and behavioral health, we're freaked out about collecting data, and our reaction to numbers and data and graphs, people just get freaked. Next slide, please. But in terms of creating this type of culture, we really do need to look at the process of therapy, the working relationship, and overall well-being of the patient. And receiving formal feedback, ongoing feedback from clients has clear-cut benefits. This is part of what we have to make sure that our culture and our treatment providers understand. It's not just about them, it's actually boosts effectiveness of their therapy, their treatment, including enhancing their well-being and decreasing the dropout rates and the no-shows. And it makes sense. Once the therapist knows precisely how the client is feeling, they're much more equipped to adjust their treatment accordingly, help them understand what we're after and how well we're getting there. It's really an opportunity for the therapist to hear honest feedback from their patients and to feel safe that they won't be retaliated against for any negative feedback that they might get. Next slide, please. It's hard for people to hear this. Feedback-informed care, it's hard for them to hear actually what's going on. So some of the feedback that we get and some of the comments that our clinicians make is, my other patients like me, the patient just doesn't want to get better, or this score makes me look bad. I'm going to get fired. These are some of the comments as you begin to institute this as part of your culture, what stands behind people's defensiveness about it. And some people were trained in a psychodynamic, almost analytic model, which actually looked at projective identification and a psychoanalytic sense that's the therapy, is analyzing the projections. This is different. This actually takes the patient as the honest recipient of care as a consumer. And the feedback becomes important, not only for the therapist in terms of the treatment, but also understanding the person. Next slide, please. Looks like these came up. So these are some of the fears that people have. So examples in clinical practice, I want to give you some examples of how it's being used. Next slide. So this organization uses completed by the client before the session, and it asks the question, looking back over the last week, including today, help us understand how you've been feeling by rating how well you have been doing in the following areas of your life, where marks to the left represent low levels and marks to the right indicate high levels. And then they're checking off their personal well-being, interpersonally, how well they're doing in terms of family, close relationships, socially, school friendships, and overall, and they give a rating to that. Next slide. Then after the session, they're asked, please rate today's session by clicking the nearest to the description that fits your experience of our session. Relationship, I did not feel heard, understood, and respected. To the left, on the right, I felt heard, understood, and respected. Goals and topics, we did not work on or talk about what I wanted to work on and talk about. On the right, we worked on and talked about what I wanted to work on and talk about, and people are rating it across the board. The therapist approach is not a good fit for me. The therapist approach is a good fit for me. Overall, there was something missing in our session today, or today's session was right for me. So that's what this organization does and at every session. Next slide. They do it also in this organization for children, giving it to the kids. Listening, did not always listen to me. Listen to me. How important. What we did and talked about was not really that important to me. What we did and talked about was important to me. What we did, I did not like what we did today. I liked what we did today, and overall, I wish we could do something different versus I hope we do the same thing, same kind of thing next time. So getting these surveys leads to more conversations, again, between the child and the therapist, and previously between the adult and the therapist as well. So using these as indications of improvement. Next slide. Here's another organization that looks at, you're not going blind. This is not something that we can share in detail, but I can describe some of what this shows you, is that this is an organization that uses the PHQ-9, elements of the GAD-7, as well as functioning status, as well as goodness of fit and alliance, and they get a score, and the score gives a global distress score plus a goodness of fit and relates the two, how well somebody's improving and the goodness of fit. Next slide, please. Once again, it's this is a alliance feedback enables a fit between the client expectations and the preferences of services, and again, using the alliance actually improves outcomes by many studies. Next slide, please. This is what this organization asks. If you had a visit in mental health department, circle the number that best matches your feelings about your most recent visit, and this is given you typically either before or after the visit. Some organizations do it before and some do it afterwards. In this session, we discussed the things that are most important to me. I felt understood and respected by my clinician. I understand and agree with my treatment plan. And the categories are only a little or not at all, sometimes quite a bit and totally. And it gives a score. And then it's again used and can relate again to the previous elements that we looked at in terms of their depression score, their anxiety score, their functioning score, and gives you a way in which to not only talk about the goodness of fit, but also talk about whether or not they're progressing in their treatment. So again, it's combining two things. One is measurement-based outcomes, how well is the patient progressing in treatment, and the alliance, and correlates the two. Next slide, please. So this is given at the beginning of the session, and as they pay, and it's reliable and valid, and they've been giving it for thousands of patients. Next slide, please. What they have found is that there's a significant relationship between improvement and asking about the alliance. The left-hand side is the severity adjusted effect size, again, back to the effect size, the progress in treatment, and relates it to the goodness of fit. The more times these patients were asked about the alliance, just asked about the alliance, the more improvement they showed in treatment. Next slide, please. So how else is it being used? So if somebody's not progressing in treatment, it doesn't look like we're getting anywhere. Let's go over the goodness of fit to make sure you are getting exactly what you are looking for. It can help you and the client get a better sense of what may or may not be working in treatment. It becomes a key. And in this organization, they're using it every session, and they're discussing the alliance at every session and what happened during the care. This organization is also using it in groups, and we'll talk a little bit more about group psychotherapy and getting a goodness of fit not only for the individual, but actually you can measure it for the group. Next slide, please. So there's another way of looking at this various measurement-based care as well as alliance. Lucid, which is, some of you may know it as Tritium, New Directions, Behavioral Health, and Tritium combined to form an organization called Lucid. And Lucid comes up with a TPI, a score, a Treatment Progress Indicator score, which is an electronic mental health assessment that's been used in psychiatry, addiction medicine, and behavioral health specialty care that looks at the different elements that we've been talking about. Next slide, please. Lucid talks about their measurement-based approach. Their electronic-based approach is like doing a blood pressure check at every session, looking at preventing suicide, as well as having clinical prompts to show whether or not somebody's actually improving or not in treatment. Next slide, please. What they look at is a number of different domains in terms of mental health assessment, including suicide risk, harming to others, depression, anxiety, PTSD, alcohol use, drug use, and subjective well-being in terms of functioning, psychiatric history, psych medication, their use and the barriers of the use, and again, the treatment alliance. And they claim it takes 3 to 5 minutes to fill out and look at. I think that's a little bit optimistic in terms of what some of the feedback that I've gotten about using Lucid. But it does produce a severity index, which tells you how well the patient's progressing. It gives a level of distress, and also can prompt you if somebody's changed and not on course in terms of their treatment, and perhaps in an emergent state using the CSSRS and PHQ-9. Next slide, please. So this graph shows again, attending to the scores reduced distress and clinical improvement. And so you can see on the graph when they started attending to the scores in terms of both their scoring as well as the relationship, the patient's symptoms severity starts to decline. Next slide. It's not just enough to give the forms, but this graph shows you it's critical to talk about it. So on the left-hand side, the variable of goodness of fit on the left shows quite a bit of variability to it, but on the right, as the goodness, the consistency of goodness of fit after clinician began discussing response with the patient, you can see the decline in their symptomatology. It's not just measuring goodness of fit, it's talking about it, and that leads to the improvement. It's that interaction, again, between the therapist and the patient and the client that makes the difference, and using it to improve care, or in some cases, to stop care or change care. Next slide, please. So, it's important to know that, we basically have two choices. Either the person's improving or they're not. If not, the client is at risk. And engage the client in a discussion about the progress and what should be done differently if there isn't any. Keep clients engaged so that a new direction can be planned. This isn't really rocket science. This is about talking to the person about whether or not they're improving in care, noticing not only their clinical scores in terms of whatever measures you're going to be using for improvement, but also looking at the therapeutic alliance. And if one or the other is off, then you have to really discuss whether or not you need to continue to treat the patient or you need to change the treatment. Oftentimes we get stuck in doing the same thing time and time again, irrespective of whether or not the patient's improving. And again, we go back to, well, it's all about them. It doesn't have anything to do with the relationship. It is that psychodynamic, psychoanalytic way in which we start thinking about patients. Next slide, please. The other thing that you notice and been noticed, and this is a UK study from Cambridge that looked at literally thousands of patients over time and found that early change is the rule. Early change in treatment is the most clear indicator and predictor of outcomes and retention in treatment. If someone's not improving early on, the likelihood that they're going to progress and they're going to stay in treatment declines. We've got to measure the outcome. We've got to know whether or not somebody's getting better early on, because that's where change starts to happen most quickly, the first several sessions. In fact, the prediction is actually 2 to 3 sessions. If there's no change after 2 to 3 sessions, the likelihood that someone's going to progress if we keep going on the same course is very poor. Next slide. It can also help, and this is a sensitive slide because it looks at an organization that compared 22 different therapists in their organization, and it really looks at each of the counselors' outcomes. And you had to have 30 or more patients for them to be listed on this. And you can see the variation between the therapists. Some of them are at the top and some of them not. And so what do you do with this kind of information? How do you manage it in terms of your organization? What kind of feedback can you give to your organization, to your providers? If someone's consistently not doing well, and you can see the arrow on the particular individual, they're not doing their patients any good. And I think that's an important thing for you as an organization and as a provider group to know about, whether it's your psychiatrist or whether it's your psychologist or your therapist. If what they're doing is consistently not showing positive results in their patient population, you have to understand why that is and support them. Maybe it's the way in which they talk to people. Are they asking the questions? How are they asking the questions? It really gives you insight into your organization and to your providers. And in terms of your organizational brand, if people are walking away saying, this organization doesn't treat me well, one negative experience, somebody who has a negative experience in an organization talks to 15 people about it. So there's a ripple effect when people do not find what their organization is doing very helpful. And so this is the kind of thing that can poison your brand or your organization if you have a group of providers who actually are not showing that they're effective in terms of the care that they're delivering. It also, next slide, please, using feedback-informed care can also help you in terms of the frequency with which you see clients. And this organization uses information to see clients more frequently when the slope of change is steep. That means that they're really working fast and working well with the patient, and they're improving, and you want to continue to really see them more frequently. As they begin to space the visits, as the rate of change lessens, as patients begin to plateau over time or stay below, the subclinical lines, but there's a clinical cutoff here, you'll notice. If they're below the clinical cutoff and they're really more stable and not necessarily improvement, that's a really good time to say to the patient, maybe we don't need to see you every week or every 2 weeks. Maybe we can see you monthly just to keep in touch. Or it gives you a chance to be able to say to the patient, look, you're at a subclinical level clinically, and we've done our job. You're doing better. You can use your $30 per session or $150 per session. Go entertain yourself in some other way. Go take a trip. It really helps an organization understand when a patient has made a meaningful change, and when it's best to increase treatment and decrease treatment and end treatment by having the ability to actually go ahead and measure people's improvement and also measure the relationship. Next slide. It's really important if you see a patient does improve, it's an important step to really let the patient know that you emphasize that the improvement is the consequence of their effort, not your effort, their own effort, and make sense of its meaning so it repeats in the future. And I think that's really an important element of any treatment, is patients really understanding what is it that they're doing that's making a difference in how they're improving in the future. And frankly, that ability to give feedback to their therapist or their counselor or their psychiatrist does have a generalizable effect in the rest of their lives, and being able to have the types of relationships that are more honest for them, and they feel less risk in the future. Next slide, please. I think this is the end. I want to thank you guys for attending today. If there's any questions, 1 or 2 questions in the chat, I'm happy to respond.
Hi, Stuart. Thank you very much. I've checked the chat. It looks like people have been pretty quiet today, so we're going to have a little bit earlier run on our evening. I want to thank you again for today's presentation. I want to remind everybody that the slides and the recording for this will be archived on the Open Minds website starting tomorrow, so we will have Dr. Buttlaire in perpetuity at the Open Minds website. Also, I want to remind everybody that we're back next week, June 13th, for our next roundtable, Improving Outcomes for Criminal Justice Involved Substance Users, Heather Doyle's SHAPE model case study. To register for that event or for a full list of upcoming roundtables, you can visit the Executive Roundtables page under the Events tab at www.openminds.com. Dr. Buttlaire, thank you again. This has been very informative, and we hope to hear from you soon.
Thank you very much. Bye-bye, everybody.